So first of all, thank you so much for taking our time. I know it is a Monday. It is a busy day for all of you. But before we begin, I just wanted to basically share with you what is it that we are doing and why we are doing this. Uh, we have felt that cardiology is one aspect of our life which is touching almost everybody because of the stress that we have had in our life or we have in our life, and the kind of lifestyle. We know that diabetes, we are a diabetic nation. All of this put together, I think all of us, I can safely say that most of us are prone to a cardiac problem or a scare of a cardiac problem in our life. One of the things that we have been talking of in the many decades of conversations such as these has been that infrastructure nahi hai. The ratio of doctor to a bed or a patient to a bed available. But what has changed in the last 3 years is that technology is playing a very important role in bridging this gap. What telemedicine is doing successfully is far beyond what infrastructure, because setting up an infrastructure in a tier 2, tier 3 city could take a lot of time and a lot of resources. But today technology is bridging that gap faster and cheaper and making healthcare accessible. So when we look at cardiology, one of the things that came into our mind was that, is there something that can be done to save more lives through remote monitoring? So we thought that, to capture the essence of this, to understand if this is a reality and what is it that we could do, we thought we'll gather, some of the best names in the industry, and which is why we requested all of you to come and take time out from your busy schedule. So really appreciate your time. To support this event, we have AliveCor, which has, kind of made it possible for us to get together. So let me begin with introducing. I see that all of you know each other. So, and that is not a surprise, but for the sake of introduction, it is my duty to introduce everyone and their accomplishments. First of all, welcome Dr. Kler. So Padma Shri Dr. Kler is currently working as a chairman. Padma Bhushan, Padma Bhushan Dr. Kler is currently working as a chairman, Fortis Heart and Vascular Institute at the Fortis Memorial Research Institute, Gurugram, and Fortis Hospital, Vasant Kunj as well. Dr. Kler has completed his MBBS from Medical College, Patiala. He's done his MD in medicine and DM in cardiology from PGI Chandigarh. He has completed his MRCP from UK and then returned to India in 1989 and was one of the founding doctors of Escorts Heart Institute. And something that I learned right now while I was talking to him, that he was probably the first couple where both husband and wife are Padma awardees for healthcare in the country. So thank you so much for taking our time, sir. We have Dr. Subhash Chandra. He's the chairman and HOD cardiology of BLK Max Super Speciality Hospital and is highly trusted name in the field of cardiology. He is ranked amongst the top cardiologists in India and has successfully performed over 25,000 complex cardiology procedures, including structural heart interventions such as TAVR and LA appendage occlusion. Then we have Dr. JPS Sani. Dr. Sani is the chairman and senior consultant, Department of Cardiology at Sir Gangaram Hospital. With an experience of 39 years in this field, he has completed his MBBS from VSS Medical College and MD Cardiology from PGI MER, Chandigarh. He's a well awarded. Then we have Dr. Praveen Chandra. Dr. Chandra is a leading Indian cardiologist and chairman of. He's supposed to join us virtually. He's joining us. Yeah. So he's from Vedanta Medicity. He's recognized as one of the leaders in angioplasty in the country and proficient in a lot of devices and technologies. Dr. Rakesh Rai Sapra. He is an MBBS, MD in internal medicine, DM in cardiology, and is currently working as a senior consultant and director cardiology in Marengo QRG Super Specialty Hospital in Faridabad. He's been previously working as a senior consultant and HOD, head of cardiology in various institutions in Delhi NCR. Dr. Dwivedi, thank you so much for flying down, especially from Bangalore, to be a part of this conversation today. He is the Yes, absolutely. He deserves a special thanks. Uh, he has completed his MBBS from Gandhi Medical College, Bhopal. He pursued his MD in medicine from the same college and later did his DM in cardiology from AIMS. Dr. Bipin Kumar Dubey, uh, he's a HOD and consultant cardiac sciences at Manipal Hospital, Delhi. He's completed his MBBS from Patna Medical College, DM Cardiology from GSBMC Kanpur, and then MD Medicine from Patna Medical College again. His field of expertise includes angioplasty, coronary intervention, balloon mitral valvotomy, and pediatric cardiac interventions. Thank you so much, all of you, for joining us. I hope I've covered everyone. So, Dr. Kler, I would like to begin with you to understand how big is the cardiovascular disease problem in our country.
See, initially in India, we all knew that most of the mortality is because of the infectious diseases. So, if you compare the data of I think 1990 versus in 2016, in 1990, maybe this year may not be exact, but anyway, around that time, the non-infectious, so lifestyle diseases, they were reason for mortality of around 35-40%. 35. Most of the diseases were because of the infective disorders, malaria, typhoid, blah blah blah. But in 2016, data shows that the majority of the mortality now is non-communicable disease. 2016 it was 63.5%. The mortality is non-communicable disease. So today, if we consider in India, three major killers are hypertension, diabetes, and heart disease. When we say heart disease, we are more or less speaking about coronary artery disease. Coronary artery disease is the disease where you get blockages in the blood vessels of the heart. This disease is not limited to heart vessels. This is a disease of all the blood vessels of the body. So if you get blockages in the heart arteries, you get heart attacks or angina. If you get in the brain vessels, you get stroke. If you get blockages in the kidney artery, you kidney failure. If you get blockages in the leg artery, you get what is called as claudication. That means people feel difficulty in walking. Not only that, then a stage may come when there's rest pain and there may be limb ischemia and patient may have to go amputation in many of these situations. So the thing which we have to realize that all the three communicable diseases, the major killers, they are purely lifestyle change disorders. Whether it is diabetes or heart disease or hypertension, if you compare the lifestyle of your grandfather and my grandfather, what he used to do from morning till evening, if we start imitating him, we'll have a lot of reduction in the morbidity and mortality. Everything was physical, food was simple food, homemade food. In my school up to 10th class, I didn't know what is pizza. There was no pizza available. We used to take food at home, go to school. In the school, you just get plain water with the pump and come back and home food again. So what has happened in last 30-40 years, that availability of the food has increased. The junk food has come more and more into the society. See, many years back, some RSS or BJP leaders said, when they were talking about
recording in progress,
when the potato chips started coming to India, So he said India doesn't need potato chips, we need computer chips. And I think he was very right. So now you have every corner pizza, McDonald's and this and that. So diet has deteriorated. If you go to villages in India today, villages, I'm not talking cities, and if you ask a child of 4 years, beta, what would you like to drink? He will never say, I want a lassi or a milk. He will say, I want a Coke, I want a Pepsi, because the Pepsi and Coke, they spend millions of dollars on advertising. So what they have done is they have conditioned our mind, our children's mind, that this is the best drink to have. So the food has gone down. When the Western people realized the ill effects of smoking, and the data came, there is some distance. The data came that the smoking is really harmful for the body. It causes cancer, it causes heart disease. Many years the cigarette lobby didn't allow to publish the results. There is a lot of these things happen in the Western world also. So ultimately, the Director General, when data was published, they came out with the warning and this and that. The companies realized that their business is going to flop, so they pushed everything to the third world. So 50 years back, at least in Punjab, I never saw anybody smoking, but now you see people smoking. The smoking came, bad food came. We stopped doing exercise. People go to market for buying, vegetables on car. They don't walk. They don't cycle. And apart from food, apart from lack of exercise, there is a lot of stress in this society. This stress, even in America, for example, the bad thing is that with the so-called progress, I call so-called progress, that you have better roads, you have better car, you have remote controls, but your mental health is going down the drain. The stress in the society is so much that if I do a survey and I ask people of your age and my age, if I ask them how many people, if they give me correct answer, honest answer, are you happy and satisfied with your life? I don't know how many will come out with that. People are running. They don't know why are they running. They have no idea why they are running. I think these are the reasons which has put our country into such a bad shape. We have become diabetes capital of the world. We have become heart disease capital of the world. And hypertension, mind you, 25% of the adult population has hypertension. 25%. You can imagine how much is the quantum of problem. I tell you just a small example. We have something like 6.5 or 7 crore people with diabetes now in India. That means around 65 to 70 million people. And when I was studying in PG at Chandigarh, we never saw a patient with diabetes below 55 years of age. Practically never saw. Now you have diabetes in 30s. And not only that, you see diabetes in females. Yesterday I saw a lady had a heart attack at the age of 42. I was shocked. She's menstruating. No hypertension, but she has diabetes. So that is what has happened. And let me tell you a simple thing, that if all the diabetics, they attain their ideal body weight is height in centimeters minus 100. For example, if you are 170 centimeters tall, your maximum weight should be 70. If all of them they achieve ideal body weight, 50% will become non-diabetic right away. They will not be diabetic anymore. And the remaining 50%, their need for drugs will be 1/3. So that is the positive effect of lifestyle modification. And if we really want to prevent this epidemic, fight this epidemic of these 3 diseases in India, I think the government has to be serious, the people have to be serious, the NGOs and the press and the media, they have to be serious to spread the message of prevention. And prevention can save billions of dollars. This country, billions of hours of wasted work can be got back. So this is what is happening.
That is very brilliantly put. Dr. Subhash Chandra, sir, when people think of heart issues, most people think of something like a fatality, कि अब तो बचेंगे नहीं. And the first thing that comes into our mind is that heart related issue means heart attack, you know. So is it more layered problem than just thinking that it's going to be a heart attack?
It's largely the question which you asked me is largely deal with the awareness and education of the mass public, and that we as fraternity keep doing on a regular basis. Besides treating patients, the onus of educating society lies on us, and in that process, we all of us have been regularly doing programs on television or radio and conducting various meetings in a social gathering. And one needs to educate public about the healthy lifestyle, as we normally do. And as you asked, the heart attack or heart failure, the public should know how to distinguish between these two entities. So heart attack, as you know, is an emergency, which would happen if your arteries have blocks and there are plaque ruptures and you have to rush to a hospital for an angioplasty or thrombolysis. Whereas the damage which ensues after the heart attack and leaving the heart weak would lead to eventually heart failure, which is a chronic process. It can last for months and years. And it is there that these patients who have survived heart attack, and which is close to 80% of heart attack patients would survive. It's just minuscule 15-20% people fail to reach a hospital or die at home or in an ambulance. But 80% is a large chunk. And we got to ensure to give them timely treatment so that they don't land up in heart failure and they don't have arrhythmic death thereafter. Dr. Kler is a very big electrophysiological expert, so is Sapra, and I also deal with such patients. So if their ejection fractions drop below a level, then they are susceptible to have sudden cardiac death. It is there that you have to keep these patients under a close scanner, and you've got to see these patients more regularly. And given the current day circumstances where besides the affordability, traveling is not easy. Even people who can afford, people can't easily travel or see their doctor personally. And it is there that the meeting which you have organized here, where I see this AliveCor as one of the sponsors, the role of telemedicine is coming up on the fore. And it was realized truly in last 2 years of pandemic that very sick patients of COVID who were not able to travel and who there was a panic in society that this is the oxygen saturation, this is the blood pressure, what should I do? And we as fraternity were extremely helpful to the public, while we could console them or send them prescriptions and ask them to stay at home. Because even in COVID, just about 5% patients would need to rush to the hospital, 90% patient would just recover at home. And there it worked. So similarly, since all of us are cardiologists sitting here, the role of this modality has been brought to fore in a very, very big way. And I would love to listen a lot about it in the ensuing discussions with other experts, that how far they have been exploiting this technology and how far they have helped their patient by virtue of reaching to them without having a physical visit. So these are the two aspects of your question as I answered.
Sir, I want to ask you one thing which stems out of what you just said, that, when you're looking at technology and especially a small device like a SpO2 meter, oximeter as we know it, became a part of everybody's life. Not only a hospital which used to have it earlier or a nursing home, but people now started having it at home. What do you have to say about the correctness of the readings? Because most of these equipments which were coming in were hardly having any standards which they were maintaining. And why I'm asking you this is because the doctor were basically treating basis the reading that it was showing. So what do you have to say about this?
You raised a very important question, and I'm sure my colleagues have come across it very often when a patient out of panic will tell you कि साहब मेरा heart rate तो 120 चल रहा है सर. मैंने तुमने कैसे देखा heart rate? कि साहब ये pulse oximeter पे देखा. And there are so many caveats to this. Actually, their heart rate is very much within the range, 70 or 65 or 80. And yet, due to some odd reason, either they have an underlying atrial fibrillation or the method they're using is not correct. And the similar thing would apply for an SpO2 also. If a patient is not very symptomatic and yet his SpO2 shows 85 or 86 and he panics. So these panic situations have to be busted by educating them and ensuring that they're using the right equipment and not some local made Chinese thing. So these situations were very common in last 2 or 3 years time, ever since we have been receiving calls on phone these patients. So your apprehension is very genuine.
Dr. Dwivedi, do you think that if regular monitoring of vitals becomes a habit, then the fatalities could be reduced? Because if it's not a habit, people ignore the symptoms, as seen in a few cases that we've seen. I mean, some of the cases of celebrity deaths have come into light, but they've brought up this issue that most of the people do not even understand that they could be having symptoms which could be related to a cardiac issue because they're not so severe.
So it's a good question. The only thing is regular monitoring of vitals in whom. It can be double-edged sword. If you promote it at mass level, then the cost-benefit ratio or the convenience-benefit ratio may not fit in. So it should be in a particular subsets of population recognized, like elderly population are already having a morbidity like hypertension, diabetes, even if they don't have heart disease or a stroke. Obviously, people suffering from heart disease, stroke should be monitoring. So, this is a bit of a new thing, clinic monitoring or clinic evaluation and home evaluation. So, we are, I think, talking about the home evaluation as I understand. So, maximum blood pressure monitoring and pulse oximeter, saturation, heart rate monitoring. These are the things which they should be taught to measure and what to look for in that. That should be taught to them. So it will reduce, a lot of, many times they feel sick or mildly sick and they ignore it. That time if they check their BP or pulse oximeter, saturation or rhythm, if any of them is irregular, they know that we have to go to the emergency or to the doctor immediately. So this making it a habit will help in that subset of patients. Minus that, if we just promote in all the general healthy population who are in early 20s or 30s, no comorbidity, it may not help it. But certainly in this population. And then as far as celebrity, those deaths are concerned, there are a lot of, I think, layers and layers in that. Apart from regular monitoring of vital, teaching them, people need to be taught that, pay attention to them and come in proper time rather than ignoring them. So monitoring and then utilizing that value to seek a proper help at proper time. Both things go in hand. I think that should be emphasized.
Something.
Absolutely, sir.
See, when he asks what should be monitored normally, so there are no clear guidelines in medicine. What vital sign, what should be done? There are no guidelines, clear cut. What I will suggest from my common sense is that every adult more than 25 years of age, he should at least check his blood pressure once in 6 months, at least, normal person. And every person should have annual health checkup, which includes blood sugars, some lipid profile, and there are few investigations. They should be done minimum for everybody. And people, there is a family history of diabetes, there is family history of coronary artery disease. Somebody has died already, somebody had a bypass surgery, they have to be even more careful. Normally, these days, what we do is that the cardiac checkup is incomplete without a proper stress test. So, when we check these people, we also do a stress test, whether it is simple TMT or stress echo, there are various types. So, people who don't have diabetes, a stress test every 2 years is okay. But if somebody has diabetes, somebody has risk factors, family history of disease, then the stress test should be every year. So this should be the minimum. So what I will tell the business world people, if they can spread my message of 3 things, what are those 3 things for the public? Teach public that you may or may not invest in stock exchange. Please invest in health. When I say invest in health, we should tell all the youngsters कि जब आपकी नौकरी शुरू हो जाती है, when you start earning, please spare 10% of your income for health. Number 1. Number 2, have annual checkups, as I said before. Number 3, everybody should have medical insurance. Rather, I would say that we should request the government of this country that health insurance should be mandatory. It should not be an option. For example, I cannot take a car on the road if there is no insurance. But I can dance in the center of the highway without insurance. What is this nonsense? So health insurance is mandatory. Mandatory means people who can afford, they have to pay premium themselves. People who can't afford, for example, the government should pay the premium. That these schemes of Ayush and this and that, you don't need the schemes. You just need insurance for everybody, and it is possible. By the way, it is very much possible.
Correct.
I'll just continue to add something more on that. In fact, the common dictum which I use to educate or make our patients aware, I mean, whenever we have health talks, I always tell them to focus or try to know their numbers. This is what I stress. Like you know your house number, you know your telephone number by heart. Similarly, you should try and know your numbers, which means blood pressure number, blood sugar number, and blood cholesterol number by heart. I mean, you should be aware.
And your weight.
Weight. So you should have these numbers, these simple statistics at your fingertips. Anybody who asks you, in addition to telling your other profile, you should be able to say, my blood pressure is so much, my sugars are this much, my cholesterol. So idea is that if you're aware of these facts, then only you can try and prevent. If you try and start looking at these numbers only after you have suffered a problem, then you have already missed the boat. You already missed the prime time of saving. And basic issue of these three numbers, which I emphasize, is that blood pressure, sugar and cholesterol, all these three ailments which lead to cardiac or all variety of cardiovascular ailments, in large majority of situations, they do not cause any symptoms. So majority of the patients might be having high blood pressure or high sugar without being aware of it. So unless and until you check them, that's why we call these three ailments as silent killers. So unless and until you check them, you'll never be aware that what your figures are and what exactly you should do. So only if you're aware, you'll take some preventive measures to prevent. So you should emphasize that people should know their numbers.
You see, I would like to add a little bit. Once the question says some celebrities. So I'll tell you, just to add to that, because one of the very senior cricketer was treated by us in Gangaram Hospital. To see him, most of the cricketer came, his youngest colleagues and all that. So when they know that I'm a cardiologist treating him and all that, so they asked me, Dr. Saab, we are so fit. We have no blood pressure, nothing, everything. Then also we got heart attack. He also got and got stented. He died suddenly in cricket and all that. So what is the reason? So that's what both of them want to just emphasize, that people get their BP checked, for example, and they know that there is some symptom for blood pressure. There is some symptom for diabetes. I always emphasize there is no symptom for cholesterol. And nobody does that checking. Unless you check it, you will not know whether your cholesterol is high. And it is strongly linked to the family history. When I took the history of these 3-4 cricketers of the country who got problem, all of them had family history. Their father had heart disease in a very young age. They didn't know the cholesterol level, but they were young, is less than 60, less than 50, or their father, uncle, they were having cardiac. And they said, we are fit, but they got heart attack. When they did the angio, all arteries are blocked. Even can't do bypass surgery on them. So then they look into the number and they found the lipids are very high. So never checked it, so they got the disease. So that these are the important messages they should know, that they should control it. And I always say that every birthday, whenever with the birthday, one day before that, you get your annual check if you're healthy, so to say you're healthy, and pick up if there is any abnormalities there or not. And regular checkup, blood pressure and other things is very important.
Yeah, but I think we should tell the people that there are two kinds of fitness. One is apparently fit.
Yeah.
Another is medically fit. Whether you have been certified, cleared by a doctor, that you are really fit. That's different. He said very right. And this guy KK, that singer, I think.
Yes.
He just collapsed and died because he never had a proper TMT or proper stress test. All the vessels were blocked on his investigation, autopsy.
Yeah.
So apparently fit doesn't mean anything. And I tell you, blood pressure is called silent killer. Why? Because majority of the patients, they don't have symptoms for many years. People walk to our opening with 220 BP. When I tell you need admission, they get crazy. This guy wants to make money out of me. I'm okay. Because there are no symptoms initially. So lack of symptoms is not a guarantee that you don't have a problem. So that is what we want to emphasize.
Yeah, I think this is a very important and a very what comes out is that the only way to safeguard you, because my next question would have been, what are the symptoms? You know, if something happens to you, how do you know that there is a cardiac problem? But I think what is coming out very strongly is that the only way to safeguard yourself and protect yourself is to prevent, and the only way to prevent is to have a regular checkup and keep a track of what your body is going through.
You see,
You want to say something?
I want to say that
Indian lipid
in our
society-
country, the other issues that so your first question, I was just answering that from that
Yes.
part. We have got 60 million people suffering from the cardiovascular disease,
Right.
which includes basically most of them are the coronary artery disease and stroke, which we say combined together. And the mortality of heart attacks in our country is almost 25 to 30% of the all mortality, and still is the number one cause of death, degenerative, as Dr. Kler said. Although it is still little less than the Western world, it is 40%, but we are still catching up very fast. The number two most important fact is that in our country we get disease 10 years earlier compared to the rest of the world. What is the reason for that? So what Dr. Saab and all of they have shared with that, we are getting risk factors earlier. Hypertension, diabetes, lipids, we are getting earlier. Then tobacco is a big problem in our country. Not only not only smoking, but chewing tobacco is a big problem in our country, which is not there existing in other part of the world. Stress, of course, Dr. Saab has very well touched that stress is playing as a whole. But these are the risk factors which are highly prevalent, and when we went into more detail, is it only the risk factors which are coming earlier? We found no, it is genetic reasons also. And when we look into the data of our country, which we did a study on familial hypercholesterolemia, I mean, in which runs in family, young people getting heart attack, they have very high cholesterol. They have no diabetes, no smoking, no blood pressure, but they die with a young coronary artery disease at the age of 45 or 50. We look at the lipids, the very high LDL is 160, 170, 180. So that family alone. And now we are also finding an LPA is a very emerging risk factor which they thought earlier. We found highly prevalent in our South Asian, our country, much more than the Western population. So genetic factors are also playing a role. So all this put together, we are getting disease earlier. And so we have to be very careful about the...
When we talk about risk factors, one has to understand there are risk factors which are modifiable, that they are unmodifiable. Like family history, I can't change. No, this is unmodifiable. Being a male, we can't become a female. Increasing age, we can't stop. I can't remain 40 for the rest of my life. So these are unmodifiable risk factors. But rest of the other things like smoking, treatment of diabetes, treatment of hypertension, exercise, stress management, they are modifiable factors. And though there is a very significant role of family and gene, but we have yet not reached a stage in science that we can change the genetic constitution of the person. It is people are working on, but right now, whatever is modifiable, at least we should stress on that.
I have to say something like heart attack and heart disease in the young population. As sir has pointed out, Indians, usually we are getting the disease 10 to 15 years earlier. We are genetically predisposed. Set aside these risk factors, genetically predisposed. And nowadays, all of us are getting patients of 20s. Last month, we have got at least 3%, less than 25 years of age. Younger one was 20 years old only. 20 years old. It's so commonly it's happening. The other things already discussed like stress, sedentary habits, obesity, which is coming in younger age group. One thing, this Indian Lipid Society, they are recommending the gift at age of 21 years. So they are saying all of us should give our children for health checkup at the age of 21 years. They are right in that. Majority, I had a few school going children, maybe 16, 18 years, plus 2 or 10th like that, having a high cholesterol level because of the bad food habits, because of the sedentary habits, not going for the play, over stress for the studies and all. So all those things are creating problem for that. So this public awareness is a must, And sir was already telling us that people are coming to us 220 by 120 BP. And they are saying, अरे तो आपको तो कुछ ये तो हम ऐसे ही चलते रहते हैं, हमको कुछ नहीं होता है. Similarly, they are talking about the sugar also. Some of them are saying
300 शुगर तो मेरा तो 10 साल से चल रहा जी, अभी तो मेरे को कुछ नहीं हुआ. So we have to create an awareness in our society. So these are the parameters, and you may not have symptoms, but in coming days you may have a big problem. So that we have to say. One thing sir was telling about the monitoring at home. So two things are there. We have to standardize the instrument. So many blood pressure instruments are there. And if you measure one BP instrument, another BP instrument, readings will vary. So there has to be some standardization of all these, like pulse oximetry, like BP monitoring, like pulse monitoring. Some standardization should be there. And the much more important thing is that how to see the BP, the patient should learn it at home, how to take your BP. That is a must. One patient is coming 2-3 times, they are taking BP, and every time is varying. This is an inherent problem with all these electronic machines. It is mentioned in some of the literature of Omron. So if you take BP in 5 minutes or 10 minutes, the readings will be varying. So that's what they are saying. If you are taking frequently BP, you have to take an average of 5 or 6 BPs. Then it will give you a correct answer.
Got it.
Yes, I agree. This type of education, like you were asking about saturation monitoring.
Yes.
So person has to know how exactly he should look at the saturation, what parameter he should see. Like one important thing which I always used to teach my patients is that when you're looking at the saturation from the machine, you have to look at the so-called plethysmograph, that the pulse wave should be visible before you start reading. If your pulse wave is visible, that means that your pulse oximeter is now sensing your pulse, and now it will give you the correct value. Because people actually had put any inanimate object inside that pulse oximeter, and it will give a reading. But you have to see that you don't straight away read that value. You see that it's actually carrying the all parameters. If you're measuring blood pressure in a wrong fashion, obviously the values will be not reliable. One last thing I just wanted to mention about this genetic predisposition, which I think is very important fact to emphasize to public, that they need to realize that Indian population, like as Dr. Sani was saying, that we have a specific genetic predisposition which possibly cannot be measured by simple parameters which we check by blood pressure or cholesterol or sugar values. There is something which is inherent in us, which has been scientifically tested, that not only Indians are getting more disease while being in India, Indians settle abroad. Indians in Canada, Indians in Singapore, Indians in various countries are showing this disease much more than their local native population. So definitely there is something inherently wrong in Indians which is predisposing them to this. And over and above that, if we don't follow a good lifestyle, definitely we are killing ourselves. So this is something which people have to realize, that they are at risk and they have to be extra and extra cautious.
Absolutely. Absolutely. Dr. Kler, I'd like to ask you that when we are looking at prevention and diagnosis specific to heart rhythm issues or something that we know as arrhythmia, how important is its diagnosis and monitoring? And is it something which is very, very common, since we're talking of genetic predisposal? Is it more common in Indians than in anyone else?
Right. See, when we come to the heart arrhythmias, there are two different categories. One is people get arrhythmias when they have practically normal heart. Then there is a second category when they have a diseased heart. So these are two very different situations. For people who get arrhythmias because of the diseased heart, and all these prevention is valid. For example, when somebody's heart gets damaged because of the heart attack, when the pumping capacity of the heart decreases, normal pumping capacity, we use the term ejection fraction, left ventricular ejection fraction. What is that? Supposing 100 ml blood comes in the left ventricle, and in one beat, how much it ejects into the body, that is the ejection fraction. So normal ejection fraction is certainly more than 55%. So 55-60% is the normal ejection fraction. When the ejection fraction drops below 35%, and we cannot improve it with some kind of medication or surgery or angioplasty, that means that has damage. So these people are prone to get sudden cardiac death, as even Dr. Chandra was pointing out. So we have to identify those people who are at high risk and give them prophylactic defibrillator. There is implantable device which is very simple to implant. It does cost money, but it is the reasonable guarantee against sudden cardiac death. So if we want to prevent arrhythmias in people with a diseased heart, prevent the disease. Okay, if we don't allow the heart to be damaged, they will not get arrhythmia. When we come to arrhythmias with normal heart, those arrhythmias are, they usually don't kill the
Recording
patient.
in progress.
They don't kill the patient, but they have repeated nuisance value. They come again and again. Fortunately, most of them, almost 95% of them, they are curable by a simple technique called radiofrequency ablation. So we go inside the heart and we burn that part of the heart which is causing the arrhythmia. There are sometimes circuits which we burn the circuit so that the circuit is broken, and the results are fascinating and very, very gratifying. We do under local anesthesia. So these are the two different kind of categories.
So,
and one thing more I would like to add, that any patient who has got rhythm problem, for example, the symptoms of rhythm problem are either they will have palpitations, or they may have dizzy spells that are going to fall, or sometimes they can have an unconscious episode, so-called syncope. So one of the best thing you can do, anybody can do, is that if you are having arrhythmia, palpitation or ghavrat, best thing is to go to a nearest possible center to go to EC done. If you can get an EC done when the symptoms are occurring, that's a true diagnosis.
Sir, I was in fact itching to ask you this when you were talking. I think in our major cities, we are well equipped with the medical fraternity, very much informed of what to do. But if you look at smaller towns and interiors of India, in case of a problem, a person goes to a general physician. Now, do you think that the medical fraternity in these areas is informed or is knowledgeable enough to identify and say that, let us check your ECG first, rather than just saying ki theek hai, kuch nahi hai, ab jao.
Well, you are right. There are challenges. For example, now fortunately tier 2 and tier 3 cities have reasonably good quality of doctors. So now the things are improved, but still there are places where there is no capable doctors available. There, all these patients are missed diagnosis, and we have seen many patients put on antidepressants or anxiety medicine. They have a real problem, but nobody has picked up.
And also, do you think there's a challenge when it comes to general physicians in these smaller towns, when this is something that I've understood over the last couple of months of researching this, that they don't have the capability to read the ECG well.
Oh, yeah. No doubt about it.
So what is it that can be done for this?
India is a very fascinating country, let me tell you. It's a very, very fascinating country. India has the best doctors in the world, and India has the worst doctors in the world. The range is so much that it is amazing. I tell you, I have worked in India, I worked in Middle East, I worked in UK, I worked in USA. The best doctors are Indian doctors. And let me tell you that you should feel proud that there is a publication from Massachusetts, Boston. These people followed 50,000 patients in that area, Boston area, over 10 years' time. And the trial result was that the patients treated by foreign medical graduates, where Indians constituted 82% of the doctors, foreign medical graduates, their outcome was better, their longevity of patients was better. So Indian doctors are very bright, but in India also it depends upon where the doctor was trained, which medical college he came to, whether he went by giving donation, or he went to the open merit, or he was taken because he belonged to some kind of reservation area. So there's a lot of variety in India. That's a problem. That's a big challenge. Actually, I was in UK, and one of the consultants here, he said, Dr. Kler, I want to ask you one thing. I never understand. Some of the Indian doctors are so bright, they are better than British doctors, but some of them, they're so dapper. What is this? And it's a reality. So there is no uniformity. See, if somebody is MRCP from UK, he will have minimum standard. But MD medicine or MBBS from India may be extremely good, may not be extremely. That's a problem.
No, but I agree that ECG interpretation and diagnosis is something where a large majority of physicians actually shy away from.
Right.
Because this is little tricky. I mean, you need to have you have to spend some time to understand this. That's why even in cardiology, all cardiologists don't try and interpret this. There is a separate subspecialty in cardiology which is called electrophysiology, where we deal with diagnosing and treating this arrhythmia. So this is something where we'll have to spend time to teach general physicians or set specific basic protocols so that they can follow for patients coming to them with some specific symptoms indicating arrhythmia like giddiness, syncope, palpitation. They should do some basic questionnaire, ask some questions, do some basic testing which includes ECG and Holter and echocardiography, and then decide whether this patient merits treatment or this does not. So if these such protocols are there, like there are such protocols there for chest pain, for anything in US or anywhere, where even a nurse can follow those protocols and make a correct diagnosis as compared to physicians. So I mean, if protocols are set, I think, and circulated to even physicians in tier 2, tier 3 or tier 4 cities, I think we can do a significant justice in improving the diagnostic.
No, actually, he's very right. The general physician in this country, see, the physicians are two types. One is who have done MD medicine. There are many who are MBBS only. They start a practice, and some of them they may be very good. But if I have to say, the average standard of ECG interpretation is very poor. And now what we have done is that from my group we have started ECG Academy. So we do webinar once a month. The first Wednesday of every month, 7 to 8, we talk about only ECG. Different topics at different scenarios. Every month we are doing for last 3 months, and now the numbers are increasing, and that actually this webinar is telecast in Bangladesh and Pakistan and Sri Lanka also. There are almost 500 people join in everything. So we want to teach ECG to those people.
One thing just I'd like to one thing which I'd like to add for arrhythmia diagnosis, like you had mentioned and Dr. Kler alluded to very nicely. There are two important aspects of arrhythmia diagnosis. One is diagnosing in people who are symptomatic. So if someone is coming with the symptoms like giddiness or episodes of unconsciousness, syncope or palpitation, then we straight away start suspecting that he could be having slow heart rate or fast heart rate. Similarly, there are a set of patients who may not be symptomatic, but they are at higher risk of getting such arrhythmias, like patients with post-MI left ventricular dysfunction. They've had heart attack, their heart is weak. Even if they are not symptomatic, they could be having asymptomatic episodes of such arrhythmias, which may not be manifesting, and their first manifestation could be a catastrophic sudden cardiac death. So there are set of situations where you will have to do investigation to pick up asymptomatic arrhythmias, and set of investigations where patients come with symptoms. So if patient is coming with symptoms, surely we'll go ahead and do ECG, Holter. If Holter is not picking, if symptoms are very, very less frequent, we may do loop recordings, external loop or internal loop recorders. All those will help. But similar testing will be required in situations where person is totally asymptomatic but at a high risk of getting arrhythmias, like post-MI LV dysfunction, or a similar situation could be like a patient having recurrent TIA or stroke, where we might suspect person to be having asymptomatic episodes of atrial fibrillation causing clot formation and embolization. So in such situations, even in asymptomatic state, we might need to investigate by doing Holters or remote cardiac monitorings in form of loop recorders, so that we can pick those ailments.
See, now the technology is going to help us. In fact, the modern medicine will be more and more technology oriented, and it is already there, but it will be amazing in future. For example, people who have got palpitation, somebody will say it happened, for 2 minutes, 3 minutes. On 2 minutes, nobody can go and get ECG done. It's too short a time. So we have devices which we can give to the patient, and what they have to just hold in the hand, and the ECG can be recorded. So like Cardia, there are many other devices, handheld devices, which can record the ECG of these patients, and many of those patients can be picked up by these methodologies.
So you wanted to say
Yeah,
something?
the same thing I wanted to tell, which already Dr. Kler has said. The arrhythmias, majority of them are like transient, coming and going type of. In that cases, the diagnosis used to be difficult. If arrhythmia is like atrial fibrillation or sometimes in the ventricular tachycardia or like the complete heart block or 2:1 block, they are coming and going. So if ECG, if it is persisting for maybe half an hour and so, ECG can be done. Even then, if the patient is reaching to the doctors and some of them are ठीक है जी ये तो थोड़ी देर में ठीक हो जाएगा, majority of them are becoming okay after some time without getting an ECG done. So definitely yes, at the time of symptoms, if you don't have, it's another problem. But if you have symptom, at least some ECG should be done at the time of symptoms. That is a must. And as the Dr. Sahab was telling, my uncle Mamaji, he was having the same syncope for a few seconds. By the time that he is going to the doctors, it's okay. And he's a CAD, post PTCA, post bypass surgery patient. So ultimately, after 6 years, we were able to find out that he was having transient complete heart block, which is persisting for a few minutes. Because of so many times Holters were done 24 hours, 48 hours, it's okay. Once we put the monitor for 10 days and 15 days, then it was picked up. He was having this type of things. So that is a really good thing.
There are many kinds of devices
Definitely,
available.
yes, technology is important in that.
People
kind of
who
cases.
have got very occasional symptoms, like once a month or once in 2 months, you can't put Holter. They're useless. You can't put Holter. We call external loop recorder, ELR. ELR can be for 1 month, but he says I get problem in 3 months time. So then there are implantable devices. It's called ILR. ILR is the internal loop recorder. It's a very small thing. It's like this much size. This can be just injected with this syringe. You inject it in 2 minutes time. The ILR has the capability to record ECG for 3 years. So when the patient gets next time behoshi or symptoms, we can interrogate from outside and it will tell what was the rhythm of that patient. So we have external, we have ECG, simple thing. We have Holter 24 hour, 48 hour, 72 hours. We have ELR, external loop recorder up to 1 month. But if the symptoms are very infrequent, then there are 2 ways. One is that we do electrophysiological study, get the patient to the lab and we can test them. Another is put them on internal loop recorder.
The other thing was that, deficiency of proper ECG interpretation in the GPs and non-major centers is partly and patchily being addressed by, a lot of systems, the third parties who are supplying, ECG and ECG interpretation, like there's a central console or monitoring system run by people. And they put these devices, ECG plus, wireless transmission devices, which will come to a central monitoring system where algorithmically it will create an alert, and that ECG will be seen by a doctor employed by that entity, and then they will tell in turn that this is a problem, you send this patient immediately to a center. Bangalore and all is being done. Earlier it was by one group. Now a few of my colleagues are doing it, and they are extending it to different places, as well as they are going for the echo also, although that's a different thing. So it made a lot of improvement in detection of ischemia and arrhythmia, especially in and around the Bangalore. So we have seen directly the technology helping us. There's a human element is there, but I was part of that algorithm cross-checking by physicians. So we had said few of them engaged in checking that it's being properly read by the algorithm generated system. So this is one thing which requires a lot of setup and manpower and all, and a routine ECG machine which transmits that. So that has been going on for some time. I think we need to step up on that.
I think my suggestion would be that I was just picking up the point which you said about the cardia. I'm a great fan of cardia, if you ask me. 2011, probably it was launched. And I was in American college meeting in USA. They were giving us $50 discount to attend the meeting and get this. So I liked the idea, so I picked up that machine from them. I think probably one of the first few in the country to get that single lead. And it is very easy to record in the ECG. Sorry.
It's on, sir. Just keep it.
Okay. So when I came as how to use this, I thought. So in my clinic, many patient complains of palpitation and all that. If you do ECG, it takes 3, 4, 5 minutes, but you have to put too many leads on that. So what I did that I kept on my table. If a patient comes like that, it takes just 1 minute to see on my ECG that whether there is a sinus tachycardia or just heart rate or there are ectopics or anything which is coming. So it gives you within a minute answer to that. So that was very useful to me. But I'll recall to few
Recording
instances.
in progress.
One was that some of my rich patients in Delhi, when they saw this with me, they said, "Doctor, we want to have also for ourselves." for our family. Although we do not have anything, but we want to have. I said, this will not diagnose heart attack. It will only give you arrhythmias, atrial fibrillation and all that. So they purchased some of them. Many times I got 2 instances after a party in the night, one of the Rotary party and all that. Early morning, 5 o'clock, got a call from one of my friends. He said, yeah, mera palpitation ho raha, ghabrat ho raha and all that. He said, mere paas wo hai. I said, bhejo. He immediately sent me, I found it to atrial fibrillation. So I said, he was just 42-year-old person, and then I had a binge drinking, 7-8 drinks. So that atrial fibrillation, I said, go and purchase Fleckerite and all that and take 4 tablets. And he became all right. So this is one of the way. Second thing I distinctly remember, when I was traveling from Delhi to London in my flight, and after 3 hours of the takeoff, there was a call came from the pilot side that any doctor in the because there is some serious problem in the. So there was a woman, 60-year-old, the British citizen, but Indian origin. She collapsed while sitting, and then the air hostess, and there were another 2 physicians sitting with them. They were there in the flight. So they found that there was no pulse, nothing, everything. So then they announced any other physician. I went there. I also went there. So luckily I had with me. I put it here. It was PSVT going on. And but there was no recordable BP. I mean, pulse was so fast, very fast for that. So we pushed her to the business class and made the letter. We tried with the carotid because at that time they were also thinking to land somewhere for an emergency landing to save this patient. And we just did it, worked without any drug. With the carotid massage, the rhythm became normal from 190 or 200, which I saw there, came to 80. Her BP came up, everything went. And then she told me she was investigated Hammersmith Hospital for this symptom, and they couldn't diagnose at that time, probably because of some reason, we don't know. And now, since I had a record, I've sent her through email, and then this was shown to the cardiologist in UK, and she was treated subsequently for RFA. And only 2 months ago, I was with my friend for a holiday in Udaipur, and that one of my friends from Gangaram Hospital, he said, ki mera tabiyat theek nahi, I'm ghabrat and all that, because he ran to see the sunset somewhere, very fast. He's 66. So he said, I'm ghabrat, heaviness or some ghabrat is there. So I had this time 6 lead ECGs because we upgraded to 6 leads now. So very useful. The moment I put it there, I found there were multiple ectopics coming. And then we can, all 6 led no STD changes, but there is no V1 to win. But multiple ectopics. So we know that there is nothing to, well, I gave him a little beta blocker and all that. He settled. So these instruments, these things are very good. And this one, I was last year the ambassador to this Apple Watch, medical ambassador, because they wanted to upgrade it. And so we said not only the atrial fibrillation, we are also picking up ectopics, both supraventricular, ventricular. We are also getting heart blocks. We can pick up by this. So it is not only atrial fibrillation. All other arrhythmias are also be picked up from the Apple Watch. So these monitoring systems are really very useful. And future, as Dr. Kler said, will be definitely working in favor for that.
No, I think it is amazing. Thank you for sharing this, because this is encouraging to know that, the technology is making the.
We had a patient. We did angioplasty in Escorts. This is 8-9 years back. So that time we used to go. Some of the patients we used to give them a device. He can put on the chest and ECG will record. So this guy, after about 10-15 days, went to New York. He was in New York airport. So he had some chest discomfort, ghabrat, and he took the ECG and he sent the ECG. It was acute stent thrombosis. So we told him that immediately go to the emergency, and he was saved. So these, anyway, the point is that all these devices, more and more will be available. They are very useful. The device has to be validated from time to time, that it is not just causing anxiety, unnecessary information. So it should be good quality device, having proven scientifically the value of that. So these devices are very useful in cardiology. There's no doubt about that.
Awesome. Dr. Subhashandra, how often do you have patients in your practice complaining of a chest pain or palpitations? And how often is it that serious that it needs immediate attention? Because the reason I'm asking you this is that a lot of people who get the chest pain sitting at home ignore it, saying that ये तो acidity है.
Very good question. Very
So,
good
yeah,
question.
good question.
If there is, before he says anything, if there is one enemy of medicine in India, that is the concept of gas in India.
Yes, and hygiene.
It's an enemy, I tell you. You know, I know patients in India, I don't know how this has come into our culture. If they have any problem in the chest, any problem in the upper part of the tummy, some of the patient, even if they have some problem in the head, they say, sir, gas ki problem ho sakti hai. You know, I don't know how it has come into our culture. So they have a gas in the brain rather than gas in the stomach. One doctor, himself doctor, he went to London. He had a chest pain. He took Pentocid. Pain subsided. Next day morning again he had a pain. This time it was a little more. He took 2-3 Pentocid. Still didn't go to the doctor. Third, he had pain again. Then he goes to emergency and he had an extensive interval myocardial infarction. And his ejection fraction dropped from the normal to 25%. This is the havoc and damage the concept of gas is doing in this country.
So a lot has been said, but to your question, as we as human beings, there are two extremes amongst us. There's a whole spectrum. So there are patients who would underplay their symptoms. A lot of them are there. As Dr. Kler rightly said, they would say it is gas or something else. There's another extreme who suffers from cardiac neurosis. They're very anxious, and any silly pain, they would say that this is cardiac pain. There's a misconception in public that the heart lies on the left side of chest. So any pain which comes from left side is a cardiac pain. And we all have come in practice now for many decades and have seen such patients. A simple reassurance would work with them. But as clinician, we got to delve deep into their symptoms, the coexisting factors. We at this stage are confused sometimes and not able to distinguish. And we err on a safer side, as Dr. Kler pointed out, that it's better for a clinician to err on a safer side so that we don't lose these patients. There have been patients who have been lost by our misjudgment, and we as clinicians presume that this doesn't look like cardiac. So to augment our thinking, there are a lot of other factors which are available, like the troponin test, which is an enzyme released during heart attack, or a simple echocardiography, which regional valve motion is very quickly picked up if somebody is undergoing heart attack in the process or in the tracks. Even ECG, serial ECGs are very important. So these 3-4 parameters, all of us regularly use them. And if we have slightest doubt, given the other factors in patient, like if they have a family history or they have diabetes, our threshold of dealing with them is much lower. We just jump on them and err on a safer side. There could be a chance that this turned out to be non-cardiac, or even a CT angiogram shows nothing. But the distinction between a cardiac neurosis and a genuine cardiac pain is very, very important. And it is there that we try to educate public also when it comes to dealing with pain, how to recognize the cardiac symptoms and when should we rush to the nearest hospital. And these devices which were discussed at great length are very, very useful tools in the current times. Dr. Sahani has it. I am surprised to see that he had it almost 10 years ago. Whereas I know about cardia just about in 2-3 years time. And it's a very, very valuable device in terms of picking up arrhythmias. The worst part of atrial fibrillation, which all of us struggle to pick up, by Apple Watch or something, is that the patients land up with a stroke. And atrial fibrillation is a very, very common problem. Almost 10% public suffers from it beyond the age of 60 years. And we invariably miss it. And the stroke would happen at the stage of transition, when his normal rhythm is going into atrial fibrillation or he's reverting back to normal. That is the time when he forms a clot in the heart, and that clot travels to the brain and he dies. So besides flecainide, which was given to control his rhythm, the most important aspect is to give them anticoagulation based on the risk of throwing embolus and landing up with stroke. So that's a real challenge globally. And it is there that the Apple study and Apple Watch has been very, very important tool. And telemedicine has, let me tell you, today if the world's population is 8 billion or so, almost 6.8, that's 80% of population today possesses some kind of phone, smartphone or any other phone. And the whole concept of, exploiting AI or this telemedicine lies in this, the very fact that the social apps are there with every human being. Why not use them to improve their health? That's the whole idea.
So, Dr. Bipin, I want to ask you that since we are talking about, the myths around where the heart is and what could be a genuine heart problem versus something which is just stemming out of your fear and anxiety, what are the symptoms that one must know as a non-medico at home to understand that this requires some attention, cannot be ignored?
Yeah, that's a good question. First thing I will emphasize that like cardiac neurosis, which is already discussed by Dr. Chandra, is a diagnosis by exclusion. If you don't have any reasons to have a heart disease, then only you can say that it's something like psychosis or cardiac neurosis. Otherwise, no. Second thing is about these symptoms. The severity of the symptoms is not directly related to the severity of the disease. In the majority of the time, like if you are having angina, it's not cardiac pain. It's just cardiac heaviness or discomfort. Only two things, not a frank pain. If you are having frank pain, most likely you are suffering from either an unstable angina or you are suffering from some kind of the heart attack. So that is one thing. Second thing is that around 20% of the cardiac pains are having in the upper stomach because of if you are having inferior wall MI. So that is the inferior wall of the heart is sitting on the top of your diaphragm. So if the diaphragm is getting irritated, you are having a symptoms in the stomach, upper stomach. And that is the most confusing thing of gas. जहाँ पर upper stomach पे pain होएगा, patient बोलेगा मेरे को तो gas बन रहा. Unfortunately, in heart attack patients, they are getting ischemia in their stomach also. That creates a gastritis and gas formation. So that is a confusing thing, and majority of them are getting relieved by some kind of antacid because that element is going off. So that is a double jeopardy. अगर उसमें थोड़ा आराम आया तो patient और आराम से सो गया कि नहीं जी कुछ नहीं है. Second problem is that the pain in the right side of the chest. Patients are always thinking left side is heart, right side is not heart. At least 5 to 10% of the patients, they are having cardiac pain on the right side of the heart. Some of them having pain in the shoulders. Some of are having the choking sensation. Some are having the pain in the lower jaw. I have couple of patients who are having pain in the lower jaw only, and all the teeth have been removed. कि वो caries है जी उसको निकाल दो. But some kind of stress as sir was mentioning, TMT has picked up that it's not a dental problem, it's a problem of heart, and that patient was got operated, bypass surgery, and still he is alive. So that is the third thing which we wanted to say. And other symptoms could be the palpitation, like some kind of feeling of your beats. That's the one symptoms. Dyspnea on exertion. Breathlessness is also important. Giddiness is another factor. If you are having giddiness, syncope, and all these 5-6 symptoms are related to your heart. So if you are having those symptoms which is persisting for some time and which is increasing during slightest exertions, like patient is going for the bathroom, or if he is climbing up a stair, he is moving around. If the symptoms are increasing, all these symptoms are increasing during activity, definitely you are having some cardiac problem rather than gas formation.
I think very important points you checked up. See, one thing is, if a patient says like this, he says, यहाँ भारीपन है, यहाँ pain है, like this, it is cardiac until and proved otherwise. That's
Center
one
of
thing.
the set, center of the chest.
Number one. Number two, if you have symptoms, even in the upper part of the tummy, if they are new symptoms, they were not happening before, and let's say you have even taken antacid, but it has not made any difference. If the discomfort or pain in the upper part of the tummy, center part of the chest, left side of the chest, right side of the chest, in the jaw, in the left arm, or any combination, continues for more than 20 minutes, one should assume this could be a cardiac heart attack. The best is, if you assume that it is a cardiac pain and it may be heart attack, one should chew 3 tablets right away, if they are available. 300 milligram aspirin, 300 milligram clopidogrel, there is a drug we can send you written form. Thirdly, 80 milligram atorvastatin. But most of the patients, they will not have these 3 drugs at home. They may have at least aspirin, or somebody close by. At least aspirin should be taken then you go immediately to a center where ECG can be done. The value of aspirin, I can tell you that if you take 1 tablet of aspirin, if the heart attack is coming, it will decrease the mortality by 25%. So this is such a weapon that instead of that antacid, they should take aspirin whenever they have in doubt.
And it has no side effects.
No, it's very simple.
Very rare, very rare. Unless you have existing ulcer, so that's not going to create a problem.
One tablet will not make any
simple one tablet is not going to have a much problem.
I will just add whatever they say that I always tell my patient that above umbilicus, if there is any symptom which comes on exertion, think that, and then it becomes all right, or you subsides on sitting or taking rest, is nothing but angina. Is nothing but heart. So I've got many patients. They said, "Kuch nahi, doctor sahab, मेरा तो gas attack की डकार आया, I felt better." So, and I asked, "When do you get this symptom?" He said, "When I was going for a morning walk. On the morning walk, I got the gas and I got the burping. I felt better. It is definitely gas." So he came and, as usual, took Dizin and all that, which is wrong. So any symptom of such nature coming on exertion, I have got a patient who was the second patient who got bypass surgery in Escorts when it opened. He only used to get toothache on exertion.
Same I had a couple
and
of
he's seen
patients.
many cardiologists. There was missed also. Went to dental surgeon. He extracted his tooth. 2 of them were removed. But he says, "I'm still getting pain on that when I walk. Those teeth are not existing at the moment." And he had a heated argument. I said, "You are definitely having heart problem." So he got angry. He said, "No, I've got this 5 cardiologists who have said nothing. Go to dentist, something. So when I had a heated conversation with him, he became very angry. I was at that time very young, just came from PGI Chandigarh. So and he said, "Now I'm getting toothache." So you just lie down. You lie down. I did his ECG, marked steady changes. I rang Naresh at that time. This is the patient I'm sending for angio.
आपने उनको गुस्सा करके ट्रिगर कर दिया था.
Exactly.
So basically, I'll say there are 2-3 things which general public need to understand about this chest pain issue. Number one, that heart pain is not only on the left side. In fact, we say anything from the lower jaw to the umbilicus, right, left, front, back, jaw to umbilicus. Any discomfort can be cardiac, especially if this pain or this discomfort is getting aggravated by exertion, getting relieved by rest. This is a hallmark of cardiac symptom. No gastric symptom would get precipitated by exertion and relieved by rest. So if that symptom is having this feature, you must assume it to be cardiac. And also, if any of this discomfort is coming out of the blue, gastric symptom doesn't come out of the blue. You might have had some extra meal, some wrong meal. You might be having some symptoms earlier. But if it's coming out of the blue in the middle of the night, you're getting exceptional discomfort in any of this region, assume it to be cardiac and get the investigation done before labeling it.
The important point is he's made very important point that any symptoms of pain, chest discomfort, घबराहट, something not good here, from here to the upper part of up to the umbilicus, if the symptoms are worsened or occur on activity and you get better by sitting, it's cardiac. On the other hand, if somebody says कि some patient says मेरे को chest pain होती है जब मैं चलता हूँ मैं ठीक हो जाता हूँ, it is highly unlikely that it is cardiac. Highly unlikely, except
and same the symptoms.
Very important in diabetic population. Remember, they don't get pain. These are the patients who get this atypical.
Breathlessness, like
if a patient
30%
has diabetes and he's come with symptoms, always say go to the hospital, get an ECG, get a troponin and all that, rule out. Even if it turns out to be gastritis, we are happy.
And if you diagnose as some simple patients are coming that he is having just discomfort, and if you say that you are having a cardiac problem, they don't believe it actually. And whatever investigations you write, they are not going to conduct it also. That is a problem with us.
Yeah, that's a negative of...
many times we have to convince them. And
got it. Dr. Dwivedi, we've just gone through a pandemic, and there have been all kinds of information floating around and usually not coming from experts. But I want to validate this, that are patients post-COVID more prone to arrhythmias?
See, we look at simply in that way that any viral infection which affects the heart also, Yeah, means I'm talking of general population, not who are already having a risk factor for the heart disease or having heart disease. Because the people who are having heart disease or having risk factor for heart disease, they can have arrhythmias even with a normal viral infection, any infection. But even people who are not suffering from any of these things, if there is a viral infection, especially if it affects the heart, and it's a new virus, so it's also finding its feet in the body. You don't know where to attack, where not to attack. So post-COVID, yes, the incidence of arrhythmias in those people have increased simply because it's a viral illness which has affected the heart also to some extent. And then this virus has affected not only the direct myocardium of the heart or the pericardium, the coverings of the heart, but causing the clotting in the system, causing stroke, also creating stress on the heart. So because of the number of cases in a pandemic and affecting the heart directly, indirectly, the arrhythmia incidence increased. The question is, for how long it will remain high in these patients? We are still finding out. That's a specific answer to your question. Anything you want to add, any of you?
Two type of things are coming in the post-COVID or during COVID. One is a tachycardia, another is a bradycardia. So most commonly tachycardia. Majority of them are having the sinus tachycardia, which persists for maybe months together. Like myself, I had a bad COVID, and this tachycardia was going on, maybe 3 months plus. 5% of the patients, they are presenting with a bradyarrhythmia, means a low heart rate. Some of them are having transient 2:1 block. Fortunately, in my experience, I want to share with all of you that majority of them are self-recovery. Maybe after 2 months, 3 months, 4 months, they are okay. So, and apart from that, some patients are having atrial fibrillation. That is a problem. I don't know how many of them are recovering after this COVID. But my patient who had the transient atrial fibrillation, all of them are recovered. So I don't know about the ventricular tachycardia because maybe they had this type of thing, may not reach to the hospital. So, but tachyarrhythmia, bradyarrhythmia, very common. Tachyarrhythmia is most common. Bradyarrhythmia is relatively uncommon. But bradyarrhythmia symptoms are much more. The patients some of them are having giddiness, some of them are having like lethargy, weakness, profound weakness type of things.
See, actually what happens that when you use this pulse oximeter or you use the BP apparatus to look into your heart rate, many times what happens, the patient has ectopics. So falsely it comes as a bradycardia. I mean, comes as a low heart rate. So they get very much worried. कि मेरा heart तो 36 दिखा रहा है, 40 दिखा रहा है, I was low. But actually it is normal because when we look into the ECU show there are a lot of ectopics there. Extra beats are there which are not measured or picked up by the instrument. So it gives you. So those type of things which we observed a lot during the COVID time, and I agree with him, the tachycardia was the most common thing and the bradycardia was there also in some group of population, younger population, no doubt in that. So those things were there, but fortunately they were...
Patients who had moderate to severe COVID, for them we recommend that after their recovery, after about 2 months time, they should have their echo and ECG. So if the echo is normal after 2 months of recovery, then it's a reasonable assurance that heart has been spared, he is fine. And in fact, patient recovered from COVID, they should not start exercise till they are cleared by the doctor. I'm not talking about mild COVID where you don't have to get admission or saturation never fell down. That's okay. They can do whatever you want. But any patient where desaturation occurred, they had to be admitted or they had a severe COVID, these patients must have a cardiac checkup 2 months post recovery to know that the heart is affected by the virus or not.
So as far as, so just put few more points that, sinus tachycardia or normal fast heart rate means, rhythm is normal, but heart rate faster has been the most common. And a lot of cases were thought to having a, subclinical or we can say very minimal myocarditis inflammation. And some cardiac markers were positive, but many of them did not have it. So it's a bit of a new entity. A lot of people have persisted for months together, and few of them have come down within a month or two. The more severe form of arrhythmias are one where the heart is much more involved, or people are having a bad lung, damage. So hypoxia and then subsequent issue causing the fast heart rate. Some cases are because of the clotting in the blood system by the virus and causing the damage to the heart in a secondary manner. Another peculiar thing is not only the virus, but the vaccines have caused similar effect in some of the cases. mRNA vaccines have known to cause myocarditis and pericarditis, causing fast heart rate, normal fast sinus tachycardia, means normal rhythm, and atrial fibrillation. And few of the vaccines which have been used in India have been known to cause in European studies clotting like virus causes, and then again cardiac damage. And then, so it's not only the virus and pandemic, the vaccines also to some extent have caused this. So whenever we had such history where we find the COVID negative, but we ask the history of the vaccination also.
But the technology, in fact, which we used during COVID time, besides the arrhythmia and all that, is the technology really helped us to manage patient during COVID when our clinics were not opened. You see, I'll give you an example of my own hospital and ourselves. We have a application software called My Follow-up, which we developed 4 years ago for our outstation patients, because you used to have a lot of patients coming from the neighboring states and all that. They can't come back again for follow-up. So we made that My Follow-up system. Very simple method where patient can log in and upload all his investigations, write his history, everything, and he can call us convenient time. He can take the appointment with us. Payment can be done, and then we have a video call and we can discuss with the patient and we can upload the prescription, signed application to that. So it takes 5 to 10 minutes minimum for that. This technology, which digital technology, was really of great help during the COVID. Even my neighbor was on that line. He could manage me through that only. So that's how it happened. So this is how we could see 40 to 50 patients a day by this method. Every day from all over the country.
No, this is very beautiful thing that you brought up, sir. Like you said, it takes about 5 to 7 minutes, but it saves you 45 minutes of driving time.
Yes.
And then saves you further waiting in the hospital, etc. So do you think that going forward, these kind of technologies is something that you would recommend people to have it at home, at least those people who are prone to a heart problem or a cardiac problem or are already heart patients? Do you think that this could be something that they could keep at home and would help them save life?
No, it is nothing. It's uploaded. I mean, you can tell your smartphone, you have to download it. You don't have this. Everything is that. So what we found, we thought that once everything will be open, it will disappear. No. If you look at my today's practice, even things are all open, my 5 to 7% of my patients are still on this of Delhi population.
Right.
What to speak about outside states are okay. They are already on this day. One of the greatest advantage has been for elderly population. Because those people, they are unable to travel to your clinic and then they have to wait for their children to go to till weekend when they get a holiday and they bring their parents to your clinic and then going back again after showing you waiting in the clinic for some time. So that, and then secondly, any time of the day, you can mutually fix up the time. Night 9:30 or I'm in the car, I can fix up the time. While my traveling time, I see 3 patients on my traveling also going back to my home. So those things have been a great advantage. If you ask me, during COVID time, the best control of blood pressure I saw.
Right.
Because the patient sitting at home, and not only best control of blood pressure, but we picked up many undiagnosed hypertensive population. Because those instruments were meant for the parents, and when they checked in the other family member, they never used to do. But sitting at home in the COVID time, they did it. And they found they're having hypertension. As Dr. Kler said, most of them are having no symptom, but they picked up. And we found there are many families, they turned out to be a lot of hypertensive population, whom we manage through the My Follow-up technology which we used. Correct. Giving them drugs through that, giving them prescription, checking it 3 to 4 times a day, a good record, which we use in office BP, we checked only once a day or maybe twice a day.
Actually, but COVID has done many good things also. COVID has, to me, I think COVID was a blessing because it taught me many things. And COVID also told us that every human being is same, whether it is Riksha Wala or Amit Shah or anybody. The COVID didn't bother about anybody. I respect COVID that way. The second thing which COVID has done is that it has accelerated the pace of telemedicine. markedly. The thing which we may not have achieved in next 10 years, we have achieved in 1 or 2 years. See, he's talking about Delhi patients. I'm telling you that so many patients, my patients from Dhaka, Chittagong, Cox's Bazar, Afghanistan, they took video consultations. I mean, you imagine how much money, time they save is amazing. And let me tell you another fact in medicine, that if the doctor and the data is sent properly and the doctor interprets it properly, more than 90-95% patients don't have to come to Delhi. You can treat them there. Only 5 to 8 or 10% patients, they need more investigation, they have to be called. So you can treat 90 patients sitting in Delhi, even if somebody sitting in Leh or somebody. India, I think India has the greatest potential of telemedicine. It will save money. And not only that, if a person sitting in Ladakh, he can have a consultation with Dr. Sani or Dr. Swachandra. I mean, he's getting one of the best doctors in the country to take his opinion sitting in Ladakh. What else you want? It also uniformizes the capability of the country to experts giving advice to very small places. So I think we need to work more. The government needs to work more on telemedicine. Of course, there has to be a little bit more legalization. Number one. Number two, the transmission clarity. We need to improve on that issue. Sometimes, patient is talking, then it gets interrupted. You lose the Wi-Fi. Those things need to be corrected, but otherwise, it's a fantastic tool. No doubt.
So
That's the only thing, sir. Whatever you are telling, that's connectivity is a problem many a times.
Right.
You are talking of 5 minutes and then suddenly it gets off.
Right.
Then again we are in problem because you have to wait for some time and then.
No,
So
it's
that's
very irritating.
very irritating. True.
No, I think when we look at technology, I think telecommunications has a very important role in the healthcare now. And
Everything, I tell you, during COVID, I have my own student. He's in Milwaukee. So his daughter was in Milwaukee and they had to marry. Engagement has to be done. Marriage has to be done. It was COVID. And the pundits had told those dates, these pundits are so very clever. So what they did was that the engagement and marriage was done on web, on the e method. So both got married. So I don't know where the technology is going. So maybe I am looking for a day when honeymoon will be also on.
And the greatest boon was medical education. You see, can you think about that? In a single day of CME, 68,000 doctors of the world were attached. You cannot think about. You have to go to travel, give a lecture. Next week I have to give a talk to Bombay. I'm sure there will be 250 people sitting there. I have to spend my whole time traveling there, staying there, giving a talk, and 250 people are sitting there, and again I come, a whole day I will waste everything, whatever. And that time during COVID, with these virtual meetings and all that, you can imagine how much benefit it gave to the medical education, and which is now going to stay. I mean,
absolutely. Absolutely.
Yeah.
Absolutely. Absolutely. So I understand very clearly what is coming out is that, in clinic monitoring is there, but support in the form of home and remote monitoring is the way forward. Right. But Dr. Kler, how do you think ECG technology has evolved? Does it meet the need gaps, especially in a country like India where such vast variations in healthcare infrastructure, purchasing power, education, there is so much of disparity around that. And like you said that, COVID has taught us that it spares no one. It's beyond all these things.
Right, like you are right, actually the technology as far as the ECG is concerned, it is very standardized already. The thing which has happened is that the machines have become smarter, smaller machines have come, which can be, portable machines are available for small places. And then now he was talking of 6-lead ECG for a small device. See, ECG has 12 leads. We have 6 limb leads, 6 chest leads. So very soon, I think devices are going to come where we can record 12-lead ECG. In those ECGs, we don't even diagnose only arrhythmia. We can diagnose heart attack. We can have a full information. So definitely, I think the thrust In medicine, is going to be technology.
So, would you want to share of any new technologies that are impacting healthcare, both in terms of the medical fraternity as well as the patients at home? Any one of you?
Technology, and especially we are talking of arrhythmias today. I think technology has made a large impact in arrhythmia diagnosis and treatment. I think if you look at the so-called impact of artificial intelligence in arrhythmias, it's a field which is possibly beyond our conceptualization. We have been talking of arrhythmia diagnosis, and AI has gone to the extent of predicting arrhythmias. Like, just to give you an example, like, whenever a person has arrhythmia, before he starts getting arrhythmias, his heart gets some changes. Like heart muscle gets hypertrophied, the fibrosis happens, chambers get enlarged. These are things which you cannot just pick on everyday monitoring. But all of these structural changes leave a signature on ECG. And these signature effects on ECG cannot be diagnosed by humans, but they can be picked up by machines. So machine learning by artificial intelligence has been able to pick these signature effects, and they have been able to predict that this person is likely to get atrial fibrillation. So he's a person who should be prevented. He should be given a means of prevention to prevent that episode, so that in future you can actually prevent stroke. In addition to this arrhythmia prevention, in fact, artificial intelligence has also gone ahead in predicting a variety of, or has shown superiority in predicting variety of other ailments. Like if we talk of stroke in patients of atrial fibrillation, largely we check by usual scoring methods like CHA2DS2-VASc scores. But the algorithms in artificial intelligence has shown superiority over those scores. Like they can predict such stroke happenings in patients with atrial fibrillation much better. Even for therapies like CRT, which patient is going to get benefited, which patient is not going to get benefited, responders and non-responders, all of this can be predicted in a much more precise fashion by use of artificial intelligence. So this is something which is beyond. In fact, I was reading that artificial intelligence can even, by looking at the ECG, can diagnose change in your emotional state. By effect of emotional state on ECG can be picked up by machine, and it can tell you that this person is going to get depressed. I mean, this is something beyond imagination. And one of the biggest challenges that we get in electrophysiology is arrhythmia ablations, where complex arrhythmias are there, where we need to map inside the heart, spend 3 hours standing in a lab, and then diagnose the loops of circuit arrhythmias. And with the help of artificial intelligence, virtual hearts can be created, virtual cells can be implanted, arrhythmias can be induced outside the patient's heart, and we can localize the focus of arrhythmia, and which can be treated, in fact, non-invasively by using radiotherapy. I mean, so these technologies are beyond imagination. Like, at least from what we learned at our times, this might become a routine thing for future cardiologists to see. Technology is definitely going far beyond what we have ever conceptualized.
Absolutely. I think, until a decade ago, when somebody would talk of these kind of things, you would doubt it, this is all fascination. But today, when somebody is talking of this, it just looks like the next thing that is going to come up and make life better. So since you're talking of artificial intelligence, Dr. Subhash, nowadays artificial intelligence is getting in almost everything. Even in diagnostics, there are AI-based interpretation support. Do you think that brings value to clinicians' decision-making in terms of directional support?
I think a lot has been said by Dr. Rakesh at great length. And AI has found such niche use in our practice, ranging from what Dr. Rakesh said, that it helps you interpret the arrhythmias it helps you create a module, a 3D or 4D module, especially in congenital heart disease, where a surgeon is very, very comfortable operating on small kids or in complex congenital heart. That's another. And that application also applies in EP. When these guys are struggling, Dr. Kler is struggling to, pinpoint the fiber where to burn. And the AI is of great help even there. Another proof of telemedicine will be that the robotic angioplasties are being done. I hope you're aware that we are sitting here in this room. The angioplasty is happening in Ahmedabad or any other city by simply the joysticks being moved by our hand. And so that is the extent of telemedicine which has gone in our field.
He's right. Surgeons have in America, they operated on a patient in Frankfurt. He's sitting in New York, moving the stick, and robotic is operating. So I think technology, I don't know, the sky is the limit in technology.
Devices which Dr. Rakesh said, the AICDs or CRTs, which are put and patient is living in Allahabad or somewhere else. The devices are Bluetooth enabled, so that their day-to-day functioning could be transmitted to you as a clinician, and then you can guide the company guy or yourself can tweak with the parameters and help him sitting right here. So if you apprise your patient about those facilities, they immediately, and it comes at a premium, but that's worth it. The Bluetooth enabled ICDs and CRTs are the way to go these days. So it helps you a lot of, saves you a lot of trouble.
Yeah, absolutely right. I mean, what I'm envisaging while listening to you is that preventive healthcare is no more restricted to the person himself. There can be guided preventive healthcare in the future.
Yeah.
In heart failure, there are modalities which can give you the fluid level of the patient, and you can, on telemedicine, you can ask him that how to increase your diuretic, reduce it, what to add.
Right.
So there are various, modalities which can apprise you about your heart failure patients.
There are publications to this effect, what he's telling. In heart failure patients, the value of remote device controlling information, they have shown that those parameters have helped to decrease the mortality in these patients. The number of hospital admissions didn't decrease so much, but mortality decreased.
Absolutely. Dr. Kler, does this AI support also empower the patient? We see that it is, and
yeah, they do. I think they do empower the patient. They give him confidence that they are connected to the medical healthcare facility. The thing is, I think he was talking about ECG, for example. Let's say anywhere ECG is done, if that doctor is not knowledgeable enough, he is not confident, there should be a way that he transmits the ECG to a central place, and there are specialists sitting and they answer like this. We have a ECG project, between me and some doctors in Punjab. So we have around 300 doctors in that. So whenever they have a patient, if they don't want to ask, they just load that ECG on that site.
right.
And we are 5-6 specialists, and 2 of them they are in America. And when we are sleeping, they see. When they are sleeping, we see. So we immediately answer that, no, this is this problem and do this. So, but centralized system, like he's telling, I think there's a great business opportunity if somebody can pick up that businessman, make such kind of arrangement that you have ECG. The whole this country is great. You can have a system where you can have ECG from Bangladesh, answer like this, and you can even earn money and do the well-being of society is also improved.
Some of the pacemaker companies are already on the way, sir. Same. They have started doing, and radiology department has done a wonderful job. The majority of the smaller cities, they have connected with the Bangalore and others. So all these reportings and everything was done by them. So that some of the pacemaker company, I know that they have started this type of thing, ECG interpretation in their lab.
So see, when a patient is coming to some doctor, let's say in Bhiwadi or in Sirsa or small place, with a heart rate of 250, believe me, many doctors themselves be very nervous. That what is this hell? Hell is happening. What to do? Kya karna hai? So if he has a capability to send the ECG to some place and get an answer within short time, it will be great help to the patient management.
Sir, I want to ask you that, what has really come out is that symptoms, prevention, people need to take care of their own health. They need to be mindful of when the pain occurs, whether they need attention or not, whether to take it seriously. Now, all this requires a lot of education. And right now, when it comes to cardiac based education, this is typically happening from healthcare providers to the patients. Do you think specifically for arrhythmia, there needs to be education beyond just the healthcare? That should there be arrhythmia advocacy that must start so that people are made aware of the risks that they are living with? Or would you think it will create anxiety and further fear in their minds?
The thing is, I think we are far behind in health education. We are far behind. What to talk of arrhythmias, we have not taught our people even simple things. An average Indian even doesn't know how much should be his weight. He doesn't know. कोई knowledge नहीं उस बंदे को. He doesn't know how much is the normal blood pressure. arrhythmia तो बहुत दूर की बात है. So what I feel is that one of the things which the policy makers have not done so far, that they have not stressed on the health education on this country. There is no state in India, including Delhi state, where there is a proper health education program. Zero. There are more than 100 Baba channels in this country. They are various kind of Sant, Sad, and they are befooling people. But there is no dedicated health channel in any state. Even in Delhi, there is no health channel. So there should be a health channel, dedicated health channel, 24 hours. They call specialists from time to time. He comes, and somebody else comes. They tell people about their health. Rather than wasting time on other things, there is nothing. And another thing which I think there is a great need now is that there should be some minimum health curriculum in schools. Like when you reach 10th class, for example, or 11th class, whatever class be, the specialist can sit and they can tell people at what level what to teach, is that minimal health curriculum के heart disease क्या होती है, blood pressure क्या होता है, diabetes क्या होती है, smoking से क्या होता है. जैसे the Western civilization has gone ahead and they at an appropriate age they tell children sex education, so that they are not misinformed, they are in the appropriate shape. But we don't have any curriculum. Zero curriculum. We are talking about mathematics and physics. We don't teach health education. This is what needs to be done at school level.
That's a very beautiful suggestion. And I'll just take the closing remarks. I know we have taken more time than what we had planned. But let's take some closing remarks, like what do you think? Where are we heading with technology? And how is it going to change our lives in the future? And certain suggestions like Dr. Kler spoke about health education in schools. So each one of you, if you would want to share what the future looks like and what should be there.
Yes, this is something which at every step, be it increasing awareness, be it increasing diagnostic methods, there has to be something happening at the central level. The government has to intervene in all of these steps to help spread the awareness and spread the effect of technology to travel down the grassroots level, so that people who are actually requiring get benefited. So I think this is something may start from a small closed room meeting, but this should travel and some policy change should happen. I think this is a very, very lovely suggestion that they should. No one ever thought of creating a health channel. Like no one talks of it, teaching people on television what blood pressure is, what sugar is. I mean, there should be a dedicated channel on this. This is such a simple concept to create and can have miraculous effects. I mean, this is
even if you don't have the dedicated channel, at least some time on the television, sometime, maybe national channel, maybe any of the private channels. Yeah, any private
Everybody
channel.
should know this is health channel.
Yeah.
You can put it on whenever you're free.
Yeah.
You see what is happening on the health channel.
Yes.
Sir, I assure you we'll do that, sir.
Okay.
We'll
That
take
is
that
great.
suggestion.
That is a great.
TV is such a media, sir, which is there even in a small village. I mean, if you start teaching this on television in a dedicated fashion, I think this
Yeah,
can
the
have
greatest example is COVID, because people are aware of the COVID because of the different channels. They are always
Right. Yeah, he's right. Actually,
yeah.
I think everybody in the world, educated, non-educated, knows what is COVID.
Yes,
This is
true.
because of media.
Everybody, because of the
So,
media.
but how many people in India know what is normal blood pressure?
True.
How many people? Even in doctors' relations, for example, they don't know because there's no health education.
Absolutely. I think, what happens is, I think in terms of COVID, we know that everyone was affected in some way or the other. But when it comes to hypertension, diabetes, cardiac issues, it's more of a reactive response to when the problem happens. Major problem happens. So I think, when we educate people that we are living with this risk all the time, and the only thing that can save you is the prevention, and the action needs to be taken by you yourself. I think that kind of a messaging needs to go out to make people
At
more
least
aware.
that will like a patient are having a lot of myth also. If they are having chest pain, they are saying that, oh, doctor is having some his own like thoughts, something like money and all things involved. So if you teach them, at least they will understand, no, this is a small chest pain, heaviness, could be heart attack, could be dangerous to you. And you have to get the treatment as early as possible. The time, everything. So time is important. You have to get the treatment within 6 hours or 8 hours or 12 hours. So if you are saying the patient, they are certainly, majority of them are denying. यार ये तो छोटा सा भारीपन हुआ, ये बोलते हैं कि हार्ट अटैक हो गया. So some kind of message should go that a small symptoms could be a harbinger for the big outcome.
Absolutely.
Science has always taught us that this beginning of atherosclerosis process, which leads to coronary artery disease, actually starts in the first decade of life. Cholesterol deposition in the heart arteries begins before you are 10 years of age, and we start talking about them when you are 40 years of age. So, I mean, this is something the teaching has to percolate down to the schools, because that is a true place where you can actually prevent disease. Primary prevention can happen there. So you have to start teaching and start incorporating such actions from school.
Absolutely.
Yeah.
Totally agree.
So if I may summarize, in a country like ours, where the doctor, nurses and population ratio is extremely skewed, there's always a dearth of good doctors and even mere doctors for the population. The ratios are very, very disturbing. The traffic situation where commuting to the hospital is a big problem. And the fact that there's a wide penetration of these apps and the smartphones in our public, I think we should exploit it to the best advantage of improving the healthcare in this country. And so I profess that as much as we can, we must use telemedicine availability. Even the co-payers now are ready to reimburse those Bluetooth-enabled device or high-end devices given to these heart failure eligible patients. So such is the future of this telemedicine, especially in our country. And I'm sure all of us have discussed in detail the various dimensions that how far it can penetrate in improving the healthcare. The medicine is a very sensitive science. It involves a lot of compassion. When we joined this profession, we got to connect with the misery and pain of your patient. And trust me, my colleagues would vouch that merely seeing his doctor on a FaceTime, without narrating any other parameters, would allay half of anxiety, half of his pain. He says, Doctor, आपसे देख लिया आपको, मैं आधा ठीक हो गया. आपसे बात अच्छी हो गई, मैं बिल्कुल ठीक हो गया.
That's right.
So you got to, connect with them on a compassionate level, and it works wonders for us. I mean, besides the real technical care of these patients.
Absolutely. Nothing works bigger and better than faith.
So I just wanted to tell one thing specific related to telemedicine, since the main thrust is on that in the coming times, and now we are also dealing right now also, but the smartwatches, the devices which a common public is using, whether they are patient or not, there will be a lot of incidents or the episodes generated by them which will alarm them to come to you and ask opinion, whether there will be false alarms or right or wrong and all. And there is a lot of cases which we will be facing it. There is no standardization how to deal with that. So we should be ready to see how we can deal with that. Means we don't have any, a body to deal with, give a guidelines on that. But this is one part of the issue about telemedicine, that smartwatch is generating a lot of alarms, false alarms. How do we deal with that? So that's just a point.
Absolutely. I think that's a very brilliant
Can I
point.
make some comments now? may not be related to topic today, but I think one thing which is seriously affecting the medical profession in India, which I have seen in last 15 to 20 years, is the progressively going lack of faith of general public in the medical profession. The eroded nobility of the profession. And it makes me very painful affair, and I feel very disgusted to see that. Why it has happened? Why it has happened is, I think there are three reasons for that, and three agencies are responsible for that. One is the press. I would say irresponsible press. Number two, politicians. Number three, some sheeps in the medical profession, doctors itself. So, how do you improve the image of medical profession? I think is a big challenge. That's what some country has to think overall. Now, the people of this country should understand that when there was a COVID, when God closed doors to them, the gurdwaras were closed, the mandir were closed, temples were closed, the churches were closed. कि मरना मरो, हम कुछ नहीं कर सकते. Then who looked after them? Doctors. And the healthcare workers, nurses died, doctors died. I think the public should understand that, number one. And the press should make them understand, because there's a lot of role of press in saying. If the press says that so-and-so hospital is doing wrong things, doing wrong angioplasty, they are all thieves, that's what has happened in the past. Now, I don't say that wrong things don't happen in the profession. They do. But why they happen? Because there is no accountability in this country. Bring medical auditing in the system. I have written a letter, email to even the Chief Minister of Delhi, that if you want to bring credibility and if you want to avoid extra procedures, why there should be X number of cesareans in any hospital? Because there is no accountability. So bring accountability into the system, and that can be brought only if there is a medical auditing. See, human beings are the same every year. American doctors are not more honest, by the way. They cannot do wrong things because there is some sword on their head. There is somebody to check them. So medical auditing is the only way to go. So these are my very strong views on this profession, and I think we need to correct that.
Absolutely, sir. I think, and I from Businessworld absolutely commit to make this happen. So we'll take your help. We'll regularly, bring this point out so that we can bring back that glory to the profession of it being considered as a noble profession and not being seen with a lack of trust. So thank you so much.